Hello, my name's Jacob White. I'll be going over a quick presentation about the pathophysiology of a myocardial infarction, as well as a few points about what occurs during a myocardial infarction, as well as the blood supply of the heart and how it actually happens. So first off, the etiology of a myocardial infarction. So the actual definition of it is just an occlusion of a coronary blood vessel, no matter where that is, within one of the coronary arteries, just actual occlusion, whether it's a plaque rupture or just lack of blood flow to that portion of the heart. So most commonly caused by a thrombus in the coronary vasculature, primarily the coronary arteries. That thrombus gets lodged in there, and the oxygenated blood is no longer allowed to travel to that portion of the heart, and therefore you start to develop injury to that part of the heart, and what we see as a myocardial infarction. So thrombus, it's caused by rupture of a plaque within the blood vessel. That plaque builds up over time within the blood vessel, and when it ruptures, it starts to clot with blood and eventually fully occludes that artery, and therefore blood is no longer able to continue on that artery, and we get the changes that we see within these patients. So thrombus causes decreased or absent blood supply to that portion of the heart, resulting in tissue necrosis. We kind of covered on that, but that's actually what occurs is when that thrombus lodges in there, we start to see tissue necrosis and the tissue dies over time if not properly treated. So I just mentioned time equals tissue. Rapid intervention is required to limit side effects as well as mortality, decrease that. So the faster we can treat these patients and reestablish blood supply to that part of the heart, the less damage we'll see, and overall the less side effects and less chance of death we'll see in these patients. So we'll go over blood supply of the myocardium. So over here you get a picture of the heart. So first off, there's the left coronary artery right here. So the actual left coronary artery, to mention it, it includes both of these strands. Those are both branches of the left coronary artery actually. So as it says in here, you have your left anterior descending, runs right down along here, and then your left marginal artery, and then your left circumflex is actually more on the posterior portion of your heart. But the left circumflex does as well come off that left coronary artery. So it kind of branches into three separate arteries along that heart. And then over on the right side of the heart, so anatomically this would be on the right side of the patient, you have the right marginal artery or the right coronary artery. So your RCA runs down and supplies that part of the heart. Also supplies a lot of the SA node in that portion of the heart as well. So if there's an occlusion within the right coronary artery, you may see some effects to the SA node as well in these patients. So there's also a bunch of veins along the heart. It's not all arteries. So there's the Thebazian veins located throughout the myocardium, and they feed the coronary sinus to allow for blood filling in the right atrium. So as we all know, within the heart, there's the right atrium where the blood fills to be pumped throughout the rest of the heart. To feed that right atrium, you need the coronary sinus, which provides a little bit of blood to it, but primarily you have your superior and inferior vena cava, which feed into that right atrium to allow for proper filling of it. And then once in that right atrium, goes through the tricuspid valve to the right ventricle, and then through the pulmonic valve into the pulmonary arteries. And then from there, it goes back into the left atrium, through the bicuspid valve into the left ventricle, and then out the aortic valve to the aorta, where it is then dispersed throughout the body. But initially out of the aorta, it's going to come right straight to the coronary arteries and feed those first with oxygenated blood. So, signs and symptoms of a myocardial infarction. Up here in it's a picture of a 12-lead EKG. So all these leads display different portions of the heart. So exactly right here you can see there's STE elevation in leads 2, 3, and AVF. That would display the right side of the heart, primarily an occlusion in the right coronary artery. So those changes right there would be indicative of a myocardial infarction in the right coronary artery requiring prompt treatment. Then there's also some depression in lead 1 and AVL, which is basically the opposite side of the heart from the 2, 3, and AVF. It's called reciprocal depression. It's also indicative that there's actually an occlusion in that right side of the heart. So some of the more common signs and symptoms: chest pain, it's overall caused by that decreased blood flow to the myocardium, lack of oxygen. Some other ones that just vary by each patient: nausea, referred pain in the arm and neck. The referred pain just means the pain's not actually caused by an issue in that arm or neck, but actually it's referred from something else, such as lack of blood flow to the heart. Diaphoresis, dizziness, shortness of breath, as well as anxiousness can all be different signs and symptoms. Of course, that all varies on each patient and their own scenario. And then also, as I showed you, the ST segment elevation on a 12-lead EKG is indicative of a myocardial infarction. And there can also be some other ST segment changes depending on the time frame of when we're seeing this patient from when the occlusion actually started. Initially, you'll go through ST depression, as we see up here, but the depression would actually be in the lead of where the injury is, not reciprocal depression. And then Q waves, of course, after injury has already occurred to the heart, you start to see a Q wave and you no longer see this ST elevation. It'd just be an actual Q wave that goes downward right before you hit that QRS complex. So also some other indicative things, cardiac biomarkers such as your troponin, as well as creatine kinase and myoglobin. They do prefer the troponin as it is more accurate of damage to the myocardium, whereas your myoglobin, creatine kinase, can also be elevated just due to damage throughout the body and other muscles, whereas your troponin is extremely accurate and indicative of damage to the myocardium of some sort. It doesn't mean there's an occlusion. It could just mean there's a cardiac contusion or some kind of damage like that, but it is indicative of the actual myocardium. And that's also noted with Barstow and Rice in a study they completed that indicated that the troponin was required and more accurate rather than doing the traditional lab values of creatine kinase and myoglobin. So complications of a myocardial infarction we might see. So cardiac dysrhythmias, there's both early and late dysrhythmias. Early dysrhythmias, that means that's seen prior to treatment. You're seeing that in your initial stages with the patient. Whereas a late dysrhythmia, that's after treatment. And late dysrhythmias tend to be permanent as your heart's damaged so much that you might have damage to your ventricles. So you're going into ventricular arrhythmias, ventricular tachycardia, ventricular fibrillation, and could overall be lethal. So these patients may require medication for the rest of their life to treat those dysrhythmias. Cardiogenic shock. So overall, cardiogenic shock is when the heart is still full of blood, but that left ventricle there fails to pump the blood throughout the body, and your heart overall can't contract properly, and therefore perfuse the tissues throughout the body. So that can be mitigated at times, but overall, cardiogenic shock is extremely deadly, even with proper treatment. And then you've got cardiac rupture. Most commonly is the left ventricular, and that was noted by Hubbard in a study he did. But as we see on this ultrasound, this has cardiac rupture, but the rupture is actually in the right ventricle. You can see the left atrium, left ventricle are filling with blood, but your right ventricle and right atrium do not have any blood in it, and overall it's failing to pump blood. So also you might see as a complication thromboembolisms, any kind of dislodgement of air, pericarditis, an infection of the pericardial sac, depression, and mental health conditions as well. To go back to the pericarditis, you can have something called Dressler syndrome, which is basically pericarditis post-CABG or coronary artery bypass graft. That's seen a little bit here and there and can be managed with antibiotics and aggressive treatment, though. But that goes over some of the complications you might see. So diagnostic testing, the actual test we're going to run to confirm the myocardial infarction. So most commonly seen, easy to do, inexpensive is electrocardiography or a 12-lead EKG like we showed earlier. Pretty indicative of myocardial infarctions when the elevation is seen, but can also miss a lot of infarctions, such as a patient with a non-STEMI or non-ST segment elevation myocardial infarction. Those are seen a lot, and those are caught actually with the cardiac biomarkers, so your troponins, creatine kinase, your myoglobins. All of those are going to be indicative of injury to the myocardium when you don't see the elevation. And then you might also see these patients get chest x-rays, CT scans. Those aren't really utilized to look for myocardial infarctions, but rather to cross out other conditions that can pop up and cause chest pain, and basically go through what other conditions you might think that are going on other than a myocardial infarction. So as here you can see on chest x-ray, you've got a tension pneumothorax in the left lobe there, whereas your right lobe is still expanding full of air. Your left lobe's fully collapsed pretty much and no air movements going on. So that'd be something to be used for. Use your chest x-ray to look for tension pneumos causing chest pain, infections, pneumonia, things like that. So as mentioned also by Barstow and Rice, the chest x-ray and CT scan are rarely abnormal with MIs, but they are depicted for other medical conditions that cause chest pain and those symptoms you see. So going over prevention and education of myocardial infarction patients. So to prevent these kinds of occurrences, work to lower our low density lipoprotein cholesterol levels. That'd be your bad cholesterol, whereas your HDL you want a little higher, but try to lower that LDL. We want to make sure these patients have lifestyle changes to include exercise. We don't want to treat them and then send them back home to have the same lifestyle and then come back in for another myocardial infarction later on. So we're trying to prevent those secondary MIs and look for better changes in their life. If they were a smoker beforehand, work on smoking preventing smoking in their life, help them out as needed, and get them on the right path. And then educational sessions, so to inform them about myocardial infarctions, causes, risk factors, how they can help themselves out, as well as what to do if signs and symptoms of seeing one later on in case they might have a secondary one, and how to get prompt treatment. As well as clinical visits for uncontrolled risk factors. So if you see these patients and they can't control their risk factors, they can't get their blood pressure under control, can't get their cholesterol under control, then they'll want to come back in to see a physician and try to get those lab values, abnormalities worked out and get them treated so we control those risk factors and hopefully prevent another myocardial infarction. And then in a study done overseas in Europe, they actually looked at intensive prevention risk factors. When they actually went in there, mitigated these risk factors very intensively, they did note a significant decrease in all secondary events and reoccurrences of myocardial infarction as well. So it is noted that these intensive prevention programs are actually effective. So when it comes to medical management as well as nursing management, they're pretty much similar. There's a few things nursing management may play into it. I'm not fully aware of nursing management, but I try to keep up with some of the things you may see. So a big thing, adequate pain control, keep these patients comfortable so we can try to prevent any undue stress on the heart that's not already there. Prevention of secondary clots through use of platelet aggregation inhibitors such as aspirin and anticoagulators that you might see, such as heparin and things of that nature. Thrombolytic administration. So something like T and Case may be administered to try to bust that clot and reestablish blood supply to that part of the heart. And then, of course, cardiac catheterization / stent placement. So actually going in through one of the arteries and feeding into the heart and finding that blockage and then placing a cardiac stent into the blockage to reestablish blood supply. Then coronary artery bypass graft. They try to avoid that, but in patients where a thrombolytic administration fails as well as cardiac stent, they may have to do a bypass graft where they actually do an invasive surgery and go in and graft that part of the heart to reestablish blood supply. And then some of these patients that require extensive treatment and their heart overall is going into cardiac failure, they may require a balloon pump or an Impella device for recovery. So that balloon pump's going to go up into the aorta and it's going to inflate on diastole and deflate on systole to basically allow for proper filling of the heart and push that blood back in to the coronary arteries to allow for proper perfusion. So those patients may have low systolic numbers, but you're going to augment that diastolic blood pressure to allow for proper perfusion and get good blood flow throughout the body. And then your Impella device, that's almost more used with left ventricular failure. So if they're in cardiogenic shock and absolutely failing to pump blood throughout the body, you can put them on an Impella device, which will allow for increased flow and push that blood throughout the body more efficiently to try to mitigate that issue of cardiogenic shock and blood flow failure. But Impellas more used when the heart's allowed to properly fill. So cardiogenic shock, the right atrium's filling good, just your left ventricle is failing to pump that blood. So that'd be a proper use of that. So nursing management, to go over that a little bit. Patient education, a big thing, educating the patient properly to prevent secondary MIs and issues, making sure the patient understands these risk factors and prevention, as well as a mental health assessment. Coming in, having a myocardial infarction, they may have some significant lifestyle changes that may have some effects on their mental health. So getting a good assessment of that and being cognizant of mental health issues that may arise. So prognosis, a few things play into how well these patients recover. So race can have a difference in that, size of occlusion, past medical history, current health status, as well as duration of occlusion prior to actually getting treatment. So less side effects are noted in patients without obstructive coronary artery disease. So when you have these myocardial infarctions, you have type 1 and type 2. With type 1, there's actually obstruction in the coronary artery, where type 2, there's not. So those patients with type 1 are noted to have more issues. So those with obstructive coronary artery disease require more medications and experience more in-hospital events than those without, and that was noted in a study by Chu, Lee, and Kim. They did note that not having obstruction allowed for less issues later on in life and less treatment required. So, and up here is just a picture depicting blood flow throughout the heart, kind of covered earlier, but it also goes over right atrium, tricuspid valve, the right ventricle, so on, so forth, until it's the left ventricle, and then comes back out throughout the body and pumps throughout. But important thing to know, veins bring blood back to the heart, whereas arteries push blood out to the tissues for perfusion. So new research and the trials they're actually going through, looking at differences in type 1 versus type 2 MIs. Type 1 myocardial infarction, you have coronary plaque rupture, arterial thrombus. And then type 2 myocardial infarction, there's an oxygen supply mismatch similar to the myocardium, possible shunting. Overall, there's still blood being pushed to the heart, but it's lacking the oxygen attached to that red blood cell, so therefore causing ischemic damage and can be significant for myocardial infarction. So it's important to get accurate diagnosis of type of myocardial infarction, as it's critical to get that precision treatment, as if you're giving a thrombolytic to a patient with a type 2 that has no thrombus to actually get rid of, that thrombolytic can be pretty hurtful and actually cause increased bleeding and side effects. And that was also noted by DeFlippis, Nasser, and Blaha in a study they did. And then also they've kind of noted new research. There's these very specific metabolic changes that have been noted with type 1 myocardial infarctions and are extremely specific to that and may require some treatment later on once they get more research done on it. They haven't gotten enough research done on these metabolic changes to actually provide treatment, but they are aware that they are occurring with those type 1s. So here's just my references went through. Appreciate you coming to this presentation, and thank you.